Hi everyone, Dr. A again. We're going to look at blood vessel disease. This is really the lipids chapter, is what it is. Alright, so we're going to start with the first general knowledge question. The buildup of plaque in arteries, what is it called? Is it called atherosclerosis or arteriosclerosis? Good question. If you're not sure, look it up and then put me the answer. And if you're on YouTube, just think about it. You can always look up. So a little bit on, again, arteries versus veins. So arteries carry high pressure blood away from the heart to the peripheral tissues, and veins carry lower pressure blood back to the heart. In the pulmonary system, arteries are pumping high pressure blood to the lungs, and veins are carrying the low pressure blood back to the heart, but that blood is oxygenated when it's coming through the pulmonary veins. All right, so, and we're going to talk about, when we talk about atherosclerosis, it happens in the arteries is what we're concerned with. The Framingham study was the first study that linked the lipid levels to cardiovascular disease. So this is a study of the population of Framingham, Massachusetts, and the reason they selected that location is that there are a lot of people that stay in that area generationally, so they stay put, and so it was easier to study multiple generations over long periods of time and to try to tease out some of these relationships. Okay, so atherosclerosis, which is the correct answer. So athero, the word athero means gruel. It means, so it's some sticky, icky substance, right? And this is caused by the buildup of lipoproteins and inflammatory cells on the wall of arteries. And so this is important. We're going to be discussing lipoproteins, but inflammation has a big role on the formation of atherosclerosis. And if this plaque builds up in coronary arteries, then problems arise. Coronary arteries, all the arteries are supplying blood and oxygen to the heart muscle itself. So it makes sure that the heart as a pump can keep functioning. So they're very, very important. And because that Framingham study started to tease out a relationship between the lipoprotein, the lipid levels, and heart disease, the measurement of lipoprotein has become a way for physicians to assess a patient's risk of heart disease and to monitor progress in treatment. Now, I do want to take a moment here to say that lipoproteins aren't really the end-all be-all, but we have latched onto them, and there are other factors, and inflammation is a big one that can cause atherosclerosis, and which then can lead to heart attacks. So that so some of the things that have been noted is that you can treat a patient's high lipoprotein levels, so their high cholesterol, high LDL with cholesterol-lowering medications, and they can come through the ER still having a heart attack, and they're having heart attacks with low cholesterol. And so, you know, if lipoproteins were the only thing to blame, then you would then think that if your lipoprotein levels were low, your LDL and cholesterol were low, then you wouldn't have a heart attack, that you would be protected, but that's not the case. Okay, so let's go over all the different fats. So this is really the lipid chapter again. So we're going to start with fatty acids and triglycerides. So fatty acids are carboxylic acids with long hydrocarbon chains. So they're long chains of hydrogens and carbons. Fatty acids are parts of triglycerides and phospholipids, and they can be saturated or unsaturated. If they are saturated, it means that that hydrocarbon chain, all the carbons in that chain are completely saturated with hydrogen ions, hydrogen atoms. You cannot add another single hydrogen atom to the chain. Unsaturated fatty acids have at least one double bond, so it's usually one or more. And in that where that double bond is, basically you're missing two hydrogen atoms, and you could theoretically add them back in, and then you would eventually have a saturated fatty acid. Fatty acids are used for fuel. They're used for membrane structure, and they are also bioactive lipids. So fuel, as in they can be burned to make ATP, and membrane structure because they're part of phospholipids, and your cell membranes are made with a bilayer of phospholipids. So they are very important. A triglyceride is a glycerol with 3 fatty acids. That's where you get the tri, and then the glycer for the glycerol. So triglycerides that's it. It's a glycerol and 3 fatty acid chains attached to it. The main purpose of triglycerides is energy storage and insulation. So insulation as in packing fats around the body. You need a certain amount of fat in your body. You cannot have 0% body fat because your body needs to be able to insulate itself against temperature changes. And so the fat is in your body, your adipose tissue is an organ in of itself, as in it produces hormones and other things, and it's an integral part to your health. Increased triglycerides are seen in conditions such as diabetes mellitus, pancreatitis, alcoholism, and glycogen storage diseases. And as we go through, this will make sense, but if you remember from some of the anatomy, like the pancreas produces the enzymes that are needed to break down triglycerides, and so there's a relationship there. With diabetes, we're going to see the high sugar of diabetes can drive triglycerides to be high, and that has to do with what the liver does with high sugar. But we'll get there in a second. So I did want to show you an illustration of a saturated fatty acid. Okay, so here's a hydrocarbon chain, and all the white dots are carbons, and all the blue dots are hydrogen. You can see that every carbon has 4 bonds. You cannot possibly add another hydrogen to this chain. So this is a saturated fatty acid. No double bonds here. Saturated fatty acids tend to be solid at room temperature. So a lot of your animal fats, like bacon fat and butter's solid at room temperature. And then I'm going to skip this one and go down here. First, you've got your unsaturated fatty acids. So unsaturated fatty acids have at least one double bond. And where there is a double bond, it will put a bend or kink in the chain and make these usually liquid at room temperature. And it simply has to do with the fact that there's a bend. Every time there's a double bond, there's a bend. It makes it harder for them to stack, and so they stay liquid. Whereas here, with a straight conformation, you can stack the molecules neatly and tighter, and that's why they become solid at room temperature. And with the unsaturated fatty acids, if there is only one double bond, they're monounsaturated. If there are several double bonds in here, they are polyunsaturated. So some of your healthy unsaturated oils, if you will, are going to be like avocado oil, olive oil, anyway, all of those you can think of that are liquid at room temperature. And then you have your unsaturated or trans fatty acids, so unsaturated trans fatty acids. So the trans has to do with the position of the hydrogens across the double bond. So there's a single hydrogen atom, but there's one on each side, and so that's a trans configuration, whereas this is a cis configuration. The cis configuration is found in nature. The trans configuration is man-made. And the problem with this is they're first not being in their natural configuration that nature has made. These cause problems with wherever they're incorporated. So in fatty acid would be incorporated in the phospholipid for your cell membrane. So if you eat a lot of trans fats, and you end up with a lot of trans fatty acids in your cell membrane, and it disrupts the function of the cell membranes. 2 is because of the way this trans double bond works, these look essentially a lot more like the saturated fatty acid, as in it can be solid at room temperature and it can stack neatly. And so this would be like Crisco. Crisco is a trans fat. It is solid at room temperature, and it's man-made. And anything that if you read on the package and it says hydrogenated oil, likely you're looking at a type of trans fat. So be careful, these are not good for your health. But saturated fatty acids are okay in moderation, and unsaturated fatty acids are really good. Okay, so this is a little quick poll question. So is this molecule, I'm going to show you in a second, is it saturated fatty acid, monounsaturated fatty acid, or polyunsaturated fatty acid? Here's the molecule in question. So based on what we just talked about, what do you think? Okay, so next we have our phospholipids, our sterols, and our sphingolipids. So phospholipids are made of two fatty acids with a phosphate group, and they are found in your cell membranes and allow for the semi-permeability of that cell membrane. So what happens is the phosphate group is water soluble. The fatty acid is not water soluble. It's hydrophobic. This is hydrophilic. Okay, and so the phosphate group is going to face the outside of the cell, and then on the second layer is going to face the inside of the cell where water is, and then the fatty acid tails are going to be like pointed towards each other. And the fact that water doesn't mix with fat means that the water molecules can't come across unless there's a pore or channel that allows that water to go through, and it's usually a protein pore or channel that allows the water through the cell membrane. Other molecules, any fat-soluble molecule could actually just go right through that cell membrane. All right, so sterols, which are fat-soluble molecule, have a ring structure and are made from cholesterol. So cholesterol is the main building block of your sterols. Some of the other sterols are cortisol, estrogen, progesterone, pregnenolone. So these are all vitamin D. These are all sterols that are derived from cholesterol. And then your sphingolipids are also found in cell membranes, but they're found in red cell, in the brain and nerve cell membranes. So they're specialized in those areas. They are similar in structure to phospholipids, and again, in a similar location as phospholipids. So again, here is your phospholipid, polar head, non-polar tails. So water soluble, not water soluble. This is what a cell membrane looks like. So again, the heads will be facing the inside and the outside of the cell where the water is, and the tails will be facing each other. And then you can see here's your fatty acid chains. This one is saturated, this one is unsaturated. And so that will have something to do with how much saturated and unsaturated fatty acids you have, and these phospholipids will have to do with how fluid your cell membranes are. And you do want some good cell membrane fluidity. You don't want them to be stiff and hard, and that usually causes some problems. All right, and here's your sterols and what the rings look like. So this is cholesterol. You have the 4 rings here and then a chain. And if it's modified here, this is removed and modified from CH3 to CH2 with a double bond, then this is now vitamin D3. So you can see the relationship, how similar they are. And then these are some of your sphingolipids. As you can see, they are similar. We have sphingosine, ceramide, and sphingomyelin, and then your other ceramides here, your galactoceramide, sulfatide, and all that. So they also have a hydrophobic fatty acid with a polar head group. So in that way, they're very similar to phospholipids, and they're also found in membranes. So cholesterol, it's an unsaturated steroid alcohol with 4 rings that are called A, B, C, and D rings right here. And it has a single carbon-hydrogen side chain. It is synthesized in most tissues of the body. This is very, very important to remember. Your body makes cholesterol. Actually, your body makes 70% of the cholesterol that's floating around in your blood. Your body made it. Okay, made it because it needs it. Okay, so when you talk about dietary cholesterol and trying to restrict dietary cholesterol, which, by the way, the U.S. government has taken cholesterol off of the list of ingredients of concern, and they're no longer concerned about things being low cholesterol or anything like that. But only 30% of the total cholesterol in your body is really derived from what you eat. It is not a source of fuel. You cannot use cholesterol to make ATP. It is found in membranes. So cell membranes, cholesterol stabilizes the cell membranes. It's embedded throughout the phospholipids in your cell membranes. It is also the precursor to bile acids, which are needed in digestion. And these steroid hormones we were talking about, like cortisol, estrogen, testosterone, progesterone, pregnenolone. And cholesterol is what is your body takes to make vitamin D. It's converted to vitamin D using sunlight. And if you don't have enough sunlight exposure, then you can actually take vitamin D3 already made if you need to. Okay, next question. So which one of these can be burned to make ATP? So which one is an energy source or a fuel? Of all the fats that we've talked about, is it cholesterol, is it phospholipid, is it triglycerides, or is it all three? If you're not sure, rewind and go back and look. There's only one, I will give you that is used as a fuel source. So let's look at a case. So Julie is 50. She has had diabetes for a few years. She comes in for some routine lab work. After the lab tech draws her blood and spins it down, he notices that the serum looks like milk. Something's wrong. So what would cause her serum to look like milk? In another way to phrase that was then which of these test results would you be expected to elevate it if the serum looks like milk? So her test results were sodium of 140, potassium of 4, chloride 101, CO2 is 28. These are rather normal right here. Glucose is 455. That is not normal. The top of normal is 100. And her BUN is 24 with creatinine of 1.1. This is slightly elevated, so maybe a little dehydration going on there. Calcium is 8.8. That is okay, slightly low, but that's okay. Her alkaline phosphatase is 250. So if you go back to the enzymes, the alkaline phosphatase is related to bile duct function and to bones. So this is probably indicating some stress to her liver, some bile duct, maybe she's making some gallstones possibly. Her AST and her ALT are normal with 35 and 29. And her cholesterol is 500. That is not normal. You would want a cholesterol around 200 or lower. And her triglycerides are 1,200 milligrams per deciliter, and that is not normal either. Triglycerides ideally are going to be below 150. So we got some elevations right here. Her HDL is only 35. We need HDL above 60 for good health, and her LDL is 160. Again, that is a little too high. We want that lower, more like less than 130. All right, so we got some issues. I want you to think, which ones do you think is going to cause her serum to look like milk? And this is, I've got an illustration here I will click on so you can see what we talk about. So this is what we talk about. This is a milky serum. Normally this should be clear, kind of transparent. It's still yellow in color, but clear and transparent, kind of look like urine normally, but not like this. And I've seen it even like completely white. So this is not normal. And so which one of these would cause her serum to look like milk? So the answer is going to be coming up, so pay attention. All right, so next we're going to dive into the lipoprotein. So the apolipoprotein is the protein portion of lipoproteins, and its job is to bind lipids so that they can be carried through the lymphatic and circulatory system. The reason we need apolipoproteins, we need proteins that carry the lipids, is lipids are made of fat, and fats are not water soluble, so they will not dissolve properly in blood, which is mostly water. And so the way we make lipids water soluble is we coat them in protein. If they are coated in protein, then all of a sudden they're water soluble, and so that's how the body will carry lipids throughout the circulatory and lymphatic systems. So also, the apolipoproteins themselves are responsible for the interactions with the cell membranes and the different enzymes that transport the lipids to specific locations. So when lipids need to be delivered, no matter what type it is, there's some interaction between the lipoprotein that's carrying it and the cell that's receiving it, and there's this receptor interaction. And the receptors are on the lipid molecule are the apolipoproteins, and so it's that protein portion, and it's basically a signal of what it's carrying, and then the cell that needs a specific thing will put a specific molecule on the surface so that it can dock to the lipoprotein that's carrying what it needs. That lipoprotein can dock on that cell and deliver what the cell needs. So lipoproteins are clusters of proteins and lipids that are all tangled up together, and the protein makes them water soluble. Larger lipoproteins have more lipids relative to protein and are higher in density. They're lighter in density, meaning they float more. They are lighter. They are, if you will, if I have to give you an illustration, think of them as big beach balls, and they're just full of light fat. And fat floats above water, right? And so they're just big bouncy molecules that can float. And then the smaller lipoproteins we're going to see are going to be way more dense, like HDL, and you can think more of those like baseball bats or baseballs or softballs, not the bats, the balls, right? So smaller, denser in structure. Okay, so we're going to talk about the different types of lipoproteins. So chylomicrons are the largest lipoprotein and therefore the least dense. So it's your big beach ball. Okay, they float to the top of plasma that's stored and refrigerated, and their main role is the delivery of dietary lipids to either hepatic and peripheral cells. So these guys obviously will rise after you've eaten, after you've consumed a meal, especially if the meal had some fat in it. Okay. Next, you have your very low density lipoproteins, or your VLDLs. They are also rich in triglycerides. So both of these dietary lipids tend to be triglycerides. So both chylomicrons and VLDLs are rich in triglycerides. But the difference is these come from the intestines where your food's been absorbed, and VLDL come from the liver. So the liver makes VLDL with all the triglycerides that have been processed by the liver. And VLDL does account for most of the observed turbidity in fasting specimens. So if the person is fasting and the specimen is turbid, it's usually VLDL because they haven't just eaten. If the person is not fasting and this was a random specimen, which that can happen, then the high and it's cloudy, it's likely that it's due to chylomicrons. Either way, the triglycerides are the molecules that cause that milkiness to the serum. Okay. Your low density lipoproteins, now they mainly transport cholesterol. So this is the difference. We have triglycerides and other dietary lipids, triglycerides, now we're into cholesterol. And it takes cholesterol to the liver, but really, actually, from the liver makes LDL and it carries it to tissues, endocrine glands, storage sites, and all over the body. And your body needs cholesterol all over the place because you have cell membranes all over the place, and it needs it to build hormones and other molecules. And then the last one is going to be HDL. It's the smallest and most dense of the lipoproteins, so that one is the baseball. And it's synthesized in the liver and intestines, both, so liver and intestines. And it has the ability to remove cholesterol from the cells, so it tends to, what it does is it goes to the peripheral cells, picks up waste cholesterol, and takes it back to the liver for disposal. Now, if we stick with our ball analogy, so chylomicrons were beach balls and HDL were baseballs. LDL and VLDL could be like volleyballs or soccer balls. They're a little bit bigger, but smaller than a beach ball, and a little more dense than a beach ball, but not as dense as a baseball. There you go. So here they are illustrated with sizes. So here's your chylomicron, has mostly triglycerides with some free cholesterol, some esterified cholesterol, some phospholipids, and some protein. And then you have your VLDL, still has a big chunk of triglycerides, but it also has more esterified cholesterol in there and some free cholesterol. IDL, again, triglycerides almost non-existent, has pretty much been delivered, but it has more cholesterol. And then your LDL has mostly cholesterol with a little bit of triglyceride and with some free cholesterol. And then your HDL is mostly picking up free cholesterol and esterified cholesterol, but it doesn't have hardly any triglycerides or phospholipids. So again, here's a little matching game. Where does it come from? So your chylomicrons are rich in triglycerides and come from the small intestine. Your LDL are rich in cholesterol. They're made in the liver and it delivers to peripheral cells. Your VLDL is also rich in triglyceride, but it comes from the liver, not the intestines. And then your HDL is made in the liver and small intestine, but it delivers cholesterol back to the liver is what it does. Okay, so that's a good little exercise to make sure you guys are following. And which one of these lipoproteins particle then would you expect to be elevated right after eating? Okay, so not a fasting specimen, right after a meal. Which one would you expect to be elevated? If you're not sure, go back to the description there of the lipoproteins. The apolipoprotein, whenever you see apo, has to do with just the protein portion of the lipoprotein. Of course, its job is to transport lipids through plasma. We've established that. There are several of them, and depending on the protein, on the apolipoprotein, you will find it on different molecules, and they have a different job in each molecule. So, for example, ApoA1 is found in HDL, ApoB48 is found in chylomicrons, ApoB100 is found in LDL, ApoC1, ApoC2, ApoC3, and ApoE are found on all lipoproteins. And then you also have lipoprotein A, and those are LDL-like particles, so they kind of resemble LDL. They contain one molecule of ApoA and a ApoB100, which is what makes it LDL-like. It is larger than LDL and has a higher lipid content and a slightly lower density. And these increased lipoprotein A are strongly associated with cardiovascular disease. So that is sometimes a measurement that cardiovascular cardiologists can take to decide if there is a high risk for cardiovascular disease. Here's another illustration of the different types of apolipoproteins and the various molecules, and you can see kind of their size relative to each other also. We have chylomicron, VLDL, LDL, HDL, and the predominant molecules are going to be ApoA1, ApoB class, but then there's also some of these other ApoE ones, and there are multiple ones. So let's go over lipoprotein metabolism by pathway. So there are 4 pathways. There's an exogenous lipoprotein metabolic pathway. So exogenous, exit means from the outside, okay? So the exogenous lipoprotein metabolic pathway is going to be dealing with the outside stuff that's coming into your body, therefore what you're eating, so the dietary fat, okay? The endogenous lipoprotein metabolic pathway, endo from the inside, is going to have to do with everything your liver makes that's lipoprotein related. We're going to talk a little bit about low-density lipoprotein receptor pathway. Also, in the reverse cholesterol transport pathway, this is where cholesterol is picked up from the peripheral cells and brought back to the liver for disposal. So they all transport dietary lipids, and they all transport either dietary lipids or hepatically derived lipids to peripheral cells, except for the reverse. It goes from peripheral cells back to the liver. And they are critical in the transport of fatty acids. Fatty acids can be generated by triglyceride lipolysis, so breaking down the triglycerides. And the main role of fatty acids is energy metabolism, is creating ATP. That is why your body likes to hold on to fat. And that's because fat in the form of triglycerides are a source of fatty acids, and fatty acids are a source of energy, meaning it can allow you to survive a famine, for example. So let's start with the exogenous lipoprotein metabolic pathways. So it starts with fat ingestion. So maybe you ate a rich breakfast of eggs and bacon, and there's nothing wrong with that. If that's the kind of breakfast you want to eat, you can eat that. And the chylomicrons are going to be assembled in your intestines, in the enterocytes, the lining cells. This is obviously after the digestive enzymes have worked to liberate some of the fatty acids and break down the fats from the food themselves. And the chylomicron is going to be packed with the ApoB48 protein in those intestinal enterocytes, and they're going to pack it full of these triglycerides and fatty acids, but also whatever cholesterol's around, phospholipids, etc. So they are formed with the help of HDL. So HDL helps and interacts with chylomicrons, and it gives it an ApoC2 protein and an ApoE protein. And you're going to see the role of these here in just a minute. And chylomicrons will activate the lipoprotein lipase receptor in endothelial cells. So those are lining cells. So those are the cells that it interacts with, and that causes a hydrolysis reaction, meaning it can release the glycerol and fatty acids from the chylomicrons, and that cell can take them up. So its uptake delivery mechanism is a chylomicron interacting and docking with lipoprotein lipase in your peripheral cells. Fatty acids are mostly delivered to muscles or adipose tissue. So if you're very active and you use your muscles a lot, then it will need to replenish the fatty acid pool in the muscles, and so it will go deliver to muscles first. But if the muscles are full up and they're good, because maybe you're not very active at all, then it's going to be adding the excess fatty acids to your adipose tissue. And then what's left after it's made all its deliveries is going to be broken down into its components. So there'll be some cholesterol left, and the other components, all that's going to be recycled in the liver, and then the excess cholesterol, all that can be made into bile or repackaged into new lipoproteins by the liver and sent back around. So this nice little graph, it illustrates what's happened. So in the intestines, in the enterocytes, you know, after ingestion of a fatty meal, the chylomicrons here are assembled with ApoA, ApoB48, triglycerides, cholesterols, and phospholipids, all packaged into that chylomicron. Now, I do want you to note that in the intestines, these actually don't go into the capillary circulation, they go into lymphatic circulation, and this is because these big old chylomicron beach ball molecules are too big to enter into the capillary circulation. They won't fit. But the lymphatic circulation has more little doorways for it to enter, and so it can enter the lymphatic circulation. Now, if you review anatomy, your lymphatic circulation eventually connects back to your venous circulation. So whatever's in your lymph tissue, lymphatic circulation, ends up in the venous circulation. So then when it hits plasma, it has its ApoA and its ApoB48. Then it's going to interact with HDL in plasma. And HDL is going to say, hey, come here, give me some of that A. I'm going to trade you some C2, C3E, and we can trade, I'll give you some cholesterol and phospholipids we can trade. Okay. Now, your chylomicron has its C2 molecule, and this is a molecule that allows it to interact with the lipoprotein lipase at muscle and adipose tissue cells. Okay, and so the muscle and adipose tissue will stick up the lipoprotein lipase saying, hey, yes, we'll take some fatty acids, and the chylomicron has to have the C2 here to deliver it. And we'll see if either one of those are missing, then we're going to have problems with the delivery of the payload here of these fatty acids and the triglycerides into the muscle or adipose, and they'll stay in the blood. Okay. Then once it's delivered, again, and all that's left is the chylomicron remnant, it's pretty much offloaded everything it could to muscle and your adipocytes. Then the C2 will be gone, and the E molecule, the ApoE molecule, is what's left, and that allows it to dock on the BE receptors in the liver, in the hepatocytes, and then the hepatocyte's going to take what's left, break it down, and recycle it. Okay, so that was the first pathway, exogenous, meaning dealing with what's coming into your body. Now, endogenous has to deal with everything that your liver makes. Okay, so your liver can synthesize triglycerides and cholesterol to be delivered in the body. So insulin promotes triglyceride synthesis from fatty acids and carbohydrates. So remember, insulin is a storage hormone. Insulin is present when you've eaten a meal and you've taken in carbohydrates and you've taken in, some fatty acids, and so you've eaten. So that raises insulin, and then what insulin is going to make sure, first it's going to make sure that your glucose and carbohydrates, carbohydrates in the form of glucose are delivered to all the cells that need energy. If the cells are all full up, then insulin is going to promote the glucose to be turned into triglycerides, and the excess fatty acids to be turned into triglycerides, and then we're going to store those. So insulin promotes storage. So insulin promotes either energy usage where there's needed, so loading up in glucose where there's needed, but if there's not a need, then it's going to promote storage, because this is all, the body sees fatty acids and carbohydrates in the form of glucose as potential energy. And you know, if you think biologically, even evolutionarily, there's been famines and then periods of lean where there's not much to eat, and that accumulation of the fatty acids and carbohydrates in the form of triglyceride allows the body again to produce ATP and to survive. Okay, so in the endogenous lipoprotein metabolic pathway, your triglycerides and cholesterol that are made by the liver are assembled with ApoB100, so this is different from chylomicrons, and they form VLDL, so very low density lipoprotein is what VLDL stands for. HDL is going to do its thing and also donate again the ApoC2 and the ApoE, which will have the same kind of role that it does in the chylomicron. So lipoprotein lipase, again on the surface of the muscle and adipocytes, will be activated by the ApoC2, just like with the chylomicrons, and that allows it to hydrolyze the VLDL and deliver the fatty acids and the triglycerides into that muscle or that adipocyte, and then what's left is intermediate density lipoprotein. So that's an LPL, it's an VLDL that has delivered some of its triglycerides, some of its payload. So it's smaller, you know, a little less dense, a little bit more dense, than VLDL. Okay. So glycerol and fatty acids are released and absorbed by the muscle in the adipose tissue there as it got delivered, and it interacted with lipoprotein lipase. And then what's left, IDLs, intermediate density lipoproteins, are then returned to the liver, and they hydrolyze broken back down. Again, glycerol and fatty acids are released in the liver, and you get the IDL remnants, and those are called LDL, and these can bind to target tissues also. So the endogenous pathway looks like this. So in the liver, it's going to assemble ApoB100, cholesterol esters, phospholipid, and triglycerides into VLDL with the B100. HDL is going to give it the C2 and the ApoE, remember? C2 and ApoE and some of the others. And the C2 will allow to interaction with LPL to deliver triglycerides, and then those triglycerides will be broken down, and the fatty acids will enter muscle and adipocytes. Okay, so then as that happens and it offloads and interacts with lipoprotein lipase, it becomes IDL and then LDL, still has the B100. That B100 receptor, there's a B100 receptor in the hepatocytes, and some extrahepatic tissue cells can interact to deliver what's left in the molecule, and also in the hepatocyte, and break it down, hydrolyze it, and the liver can process it again. Okay, so which pathway handles your dietary fats, endogenous or exogenous? You should know that. If you're not sure, go back and listen to the last 5-10 minutes. All right, low density lipoprotein pathway, or the LDL pathway. So the LDL receptor is a cell surface receptor that recognizes that ApoB100 of LDL molecules. So these LDL molecules are usually richer in cholesterol and have lower amounts of triglycerides in them. So the ApoB100 molecule can be broken down into peptides, amino acids, and cholesterol, and those are used to make cell membranes and steroid hormones. So it's the LDL receptor pathway, and the LDL molecule's job is to deliver cholesterol to the cells, because the cells need it to build new cells to put in the membranes, or to build the steroid hormones, the cortisol, the estrogen, the testosterone. So regulation of that free cholesterol by the cells is achieved by reducing the production of the endogenous cholesterol and inhibiting the LDL synthesis when cholesterol levels are high. So that's, if the cell has plenty of by the cells, if their levels, if they're full up, then they are going to try to block LDL synthesis and reduce endogenous. We don't need to make it. There's plenty. Okay, so endogenous cholesterol is the body making its own cholesterol. Why make more when there's already plenty? Okay, and we don't need to transport it if we have plenty. Okay. Due to its small size, though, LDL can infiltrate into extracellular spaces, so it can leave the blood circulation and get stuck between the cells. And if it gets stuck in these extracellular spaces, then it can be oxidized, and this is the problem. So LDL is not really the problem. Oxidized LDL is the problem. If it is oxidized, then it's going to be taken up by macrophages, which takes up the bad stuff and garbage and around your body. And this happens especially if there's excess of cholesterol. So you get a lot of oxidized LDL. And macrophages engulfing them, and as those macrophages become full of these oxidized lipid drops, then they turn into what we call foam cells, and this process is some of the process of atherosclerosis, of plaque buildup. And then the reverse cholesterol transport pathway is a process by which cholesterol is removed from the tissue and returned to the liver, usually for disposal. So there's this constant cholesterol turnover, and used up cholesterol needs to be discarded. So the main role of HDL is to maintain the equilibrium of cholesterol in the peripheral cells. So they need to have enough but not too much. And it will gain a spherical or round shape as they absorb phospholipids and cholesterol esters and fill up. And then they, from there, they'll take that back to the liver. There are three ways your liver cells or hepatocytes can take up cholesterol. Either the receptors attach to cholesterol esters and take them up straight from the HDL, so they take up the used up cholesterol, or the cholesterol esters and HDL are given to lipoproteins that have the ApoB100 protein, which would be your LDLs. Or the hepatocyte recognizes the ApoE on HDL and takes them up. And then cholesterol can be disposed of or reused if there's a need for it in the body. It's disposed of through bowel. Incidentally, if you have a lot of cholesterol in your bowel, a lot of bowel is being produced with cholesterol, the cholesterol will crystallize and can start forming gallstones. So gallstones are usually made of crystallized cholesterol. The crystals are actually quite pretty, but the gallstones are no fun. So excess glucose from carbs is converted to fat by the liver. So which pathway does it take to your adipocytes? Is it endogenous or exogenous? Which pathway do you think? If you're not sure, go back and review both pathways. All right, and which one of these would carry the most cholesterol, or would be, if you will, your primary cholesterol transporter carrying the bigger payload, I would say. So if you're not sure, you can go look it up. So let's talk about this lipoprotein lipase molecule and what happens if you don't have enough or you don't have it at all. So because this is the key receptor on the surface of your muscle cells and your adipocytes, then to pick up and to allow that release of the fat from the molecule to be taken up to the muscle or the fat cell, then you cannot catabolize dietary fat. You cannot break down that dietary fat. So then you have massive amounts of chylomicron, because every time you eat a meal that has some fat, the chylomicrons are built, but they can never deliver any of their fats to the tissues. Okay, so it is lipoprotein lipase deficiency is due to mutations in the lipoprotein lipase gene. It is a rare autosomal recessive disorder, and it's characterized by the presence of lots of chylomicrons and triglycerides levels as high as 10,000 milligrams per deciliter. This is crazy high. It's 100 times normal, okay? And because of this high triglycerides, it will trigger bouts of acute pancreatitis and trigger the production of xanthomas, which are lesions on the skin that are characterized by accumulation of a lot of lipid-laden macrophages. So they're basically fat. It's a rash where the bulbs being on the rash are full of lipids. They're xanthomas. Okay, then you have an apolipoprotein deficiency or defects. There are several of them. So we have apolipoprotein C2 deficiency. So if you remember on the VLDL and the chylomicron, C2 is the molecule that was needed to interact with lipoprotein lipase. Okay, so if that's missing, then it can't interact with lipoprotein lipase, and therefore the chylomicrons and VLDLs will not break down. Okay. So that's not a good thing either. Familial defective apolipoprotein B100. With that one, if you have a defective B100, you have a reduced affinity for that LDL receptor, and so it can't, the LDL cholesterol is going to be increased because it can't deliver that cholesterol that you have. It cannot deliver it into the cell because it needs the B100 to be able to deliver it. To interact with the LDL receptor to be able to deliver cholesterol inside the cells. Okay, so C2 is chylomicrons, therefore it's going to mess with the triglycerides being delivered. B100 is LDL, and so it's going to mess with cholesterol being delivered. Okay, and then you have hyper-apo-beta lipoproteinemia, so high levels of the apolipoprotein B beta. And those are basically increased levels of the ApoB100, and that can lead to decreased HDL levels. And then you also have defects in the synthesis or catabolism of your apolipoprotein A1, and that leads to low levels of HDL. There's also an unusual disease called Tangier disease, where you have markedly reduced HDL levels, you have a large liver and spleen, and premature cardiovascular disease, and its hallmark is orange tonsils. HDL is protective, and so you want high HDL levels, and when you have reduced HDL levels, you're always going to be at a higher risk for cardiovascular disease. Some of the familial conditions, you have familial combined hyperlipidemia, so it's a combined high lipid in the blood. So it's the most common mixed pattern of hyperlipidemia involving usually triglycerides and cholesterol. Everything's up. Familial hypertriglyceridemia, you see moderate increases in the serum triglycerides. They are not at risk for coronary heart disease, but they are at high risk for acute pancreatitis because of the high triglycerides. Then you have familial hypercholesterolemia, so this one is high cholesterol in the blood. LDL can accumulate, and then this one you can get arteriosclerosis, or the hardening of the arteries and plaque buildup. So the cholesterol levels are high. And then you have familial hypoalpha-lipoproteinemia, and so not enough of the alpha lipoproteins in the blood, and that leads to decreased levels of HDL and high incidence, again, of coronary artery disease, because HDL is protective against that. So a little bit about the role of lipoproteins in atherogenesis. Atherogenesis is the production of plaque. Plaque is what we don't want. And so the clinical significance of analyzing all those lipids is still primarily associated with their contribution to coronary heart disease and various lipoprotein disorders. So it's worth noting there are 8 different subclasses of LDL particles, and you can do an LDL particle analysis, but the smaller, denser LDL particles are more pathogenic and more problem. So there are these analyses that you can do. They just have not become part of mainstream practice yet, but they are quite useful because a high LDL may or may not give you the right risk factor indication, whereas an LDL particle analysis can give you the right type of breakdown of what is it the big fluffy ones, is it a small dense one, and you don't want a lot of the small dense ones because they create more damage in the cardiovascular system. When macrophages, we mentioned this, ingest large amounts of LDL, they become foam cells, and foam cells are found in atherosclerotic plaques. So there is definitely a relationship here. And VLDL and chylomicrons are also atherogenic, so they can contribute, their presence can contribute to plaque. Now, part of that is, and we're going to talk about it, is they could be also, one, reflective of a pattern of eating and a lifestyle, and they also could be kind of basically innocent bystanders, and they're elevated really because of diet, and part of the atherogenesis, the formation of plaque, is tied to inflammation, and inflammation is definitely tied to high insulin and high glucose levels. And so there are some relationships here in the metabolism of VLDL and chylomicrons, because VLDL come from high glucose, lots of carbohydrates, chylomicrons come from high-fat diets. And so there's some relationships there, but we just know that it's an area of concern. It's something to be monitored on patients. So HDL is referred to as the good cholesterol, and you want to see elevated levels of HDL because it can prevent atherosclerosis, because that means you're really good at removing the cholesterol and disposing of the excess cholesterol. Now, which value do you think is more important to determine cardiovascular risk? Of those, depending on what we just talked about. And I do have to mention here the Cholesterol Reference Method Laboratory Network. It was created by the CDC, and the National Cholesterol Education Program provides education to physicians and the public concerning the dangers of high cholesterol and its relationship to disease. So they're a good source of information for that. They are also responsible for those cutoff points for total cholesterol, HDL, and LDL. So like they're the ones who decided what's high cholesterol, what's normal, what's desirable, what do you want, what is best for you, according to the studies. The Cholesterol Reference Method Laboratory Network is designed to help reagent manufacturers with correlating their methods to the reference methods so that they can give accurate results that can be interpreted by clinicians. And reference methods are always lab methods that are considered to be the gold standard and are used to compare lab methods. So they're the standard against which new things are compared to make sure they match up and they correlate well with the gold standard. So of the tests that we do on blood, usually part of a lipid panel, the first one is total cholesterol. It can be performed as a single test during cholesterol screenings. It can even be done with a finger stick and a little reader like the Accu-Chek glucose meters, except this one reads cholesterol. It is always part of a lipid panel. Lipid panels will include total cholesterol, triglycerides, LDL, and HDL. And the LDL and VLDL are usually calculated based on the analysis, the results of the cholesterol, triglycerides, and the HDL. And the LDL uses the Friedewald equation to calculate these values. We're going to look at those in a second. So cholesterol testing alone does not require a fasting specimen, so that's why we can do cholesterol screenings anytime during the day, part of health clinic screenings, because fasting does not affect your cholesterol levels in any way. The reference method for cholesterol is an isotope dilution mass spectrometry method, but mostly what is used in the clinical labs are going to be enzymatic methods. Those pretty much all labs that report to CAP use that because it's a faster analysis and it is accurate. Your next value on that lipid panel is going to be the triglycerides. So this one does require a 12-hour fast because you remember meals, anything that you eat will increase, especially if it has fat, will increase your triglyceride levels. And if it had a lot of carbs, your liver can also convert it to triglycerides, and so it would increase your triglyceride levels. Okay, so if you want an accurate picture of triglycerides, there has to be an overnight fast, ideally 12 hours. The reference method is also a gas chromatography mass spectrometry method, GCMS, and involves the hydrolysis of fatty acids on triglycerides and then the measurement of glycerol. For every glycerol molecule that's present, since there's one glycerol per triglyceride, it correlates to the triglyceride amount. Clinical labs use an enzymatic reaction. Again, just like with the cholesterol, it's faster, it's better automated, you don't have to deal with the GCMS. But there are several variations on these enzymatic reactions, but all variations will use enzymes to separate the triglycerides into glycerol and fatty acids, and then couple reactions after the production of glycerol to measure the glycerol. Your high-density lipoprotein. The accepted reference method is a three-step procedure. You get an ultracentrifugation to remove VLDL, heparin manganese step to remove LDL, and then the supernatant, so what's floating on top, is then assayed using an Abel-Levy-Brody-Kendall method. Precipitation methods were used for years but have been replaced by direct measurement, also known as the homogeneous method. A first reagent is added to block non-HDLs and is followed by a second reagent that enzymatically measures the accessible HDL cholesterol. So these are the two main methods for HDL lipoprotein analysis. And then the LDL usually uses the Friedel equation. So with that, the LDL equals the total cholesterol, which you measured, minus the HDL plus the triglycerides divided by 5. And so that gives you, basically it's an estimation of LDL. If you just take the triglycerides and divide them by 5, you have the VLDL. This equation is valid only for patients with a triglyceride level that is less than 400. Because what happens if that triglyceride is above 400, when you divide, even when you divide it by 5 and add it to the HDL, this number is bigger than that number. You end up with negative numbers. You can have negative numbers of anything. So anything above 400 in your triglyceride level, you just simply cannot calculate that LDL level. And then the only way to get LDL is to actually measure it. You cannot calculate it. So direct LDL reference methods do combine ultracentrifugation and chemical precipitation, and so they will directly measure LDL. And the automated methods are similar to those direct HDL methods, where the LDL is separated from the other lipid fractions and then measured. Okay, so let's check your knowledge. So which set of values could you use to calculate an accurate LDL? So look at these sets of values. Do you remember there was one that needed to be not too high in order to work, and so pick out which one would work, and ideally then the other one would not work. And again, some notes on atherosclerosis. So it is a slow disease in which arteries slowly become clogged and harden. Atherosclerosis development can start in childhood or in the teenage years and slowly progress and develop over the adult years. It is the underlying cause of most cases of heart attacks, strokes, and vascular dementia. Fat, cholesterol, calcium, and other substances are what form plaque that slowly accumulate, which builds up in the arteries. And this is where our concern is, because arteries deliver that oxygenated blood. The hard plaque then narrows the passage of that blood flows through, so it's harder and harder for blood to flow through the passage becomes smaller, right? And that causes those arteries also to become stiff and inflexible. And you don't want stiff, inflexible arteries. The exact cause of atherosclerosis is still unknown, although we do know that it begins with endothelial cell damage to an artery. The endothelial cells are the cells that line the artery that are in contact with the blood. What damages endothelial cell? Inflammation, high glucose, high insulin, so yeah, chronic inflammation, high glucose, high insulin, high blood pressure. Those are all things. Smoke, the chemicals from smoke, all of those can damage those endothelial cells. And once damage has occurred, and platelets start to build up in order to heal the injury, and then also cholesterol and other things are deposited. So if you will, plaque is like a molecular band-aid that your body does to fix the damage, but it's more like, or molecular duct tape. And so it finds injury and it covers it up with some plaque, and then but then it's injured again, and so it covers it up with more plaque. So it's like laying layers and layers and layers of duct tape on top of it until it starts really accumulating and forming plaque. And then other things can stick to it, and so that causes this narrowing of the artery, which then eventually leads to heart attack, strokes, and dementia. Atheromas are the fancy word, medical word for plaque. And when they happen in coronary arteries, they lead to ischemia. So this is lack of blood flow. So this is a lack of blood flow to the heart muscles. So the coronary arteries feed the heart muscles fresh blood and oxygen so the heart can keep pumping. And it also leads to angina, which is chest pain, which is a symptom of ischemia. And it can cause a myocardial infarction, meaning a total blockage of that coronary artery, or near total blockage of that coronary artery, which means that anything downstream from that coronary artery, muscle-wise, is dying and being damaged because it's not getting oxygen. And if this happens, if the atheromas are in the aorta, an aneurysm could develop. So the best way to illustrate that is if you've ever seen like a water hose where the water's turned on full pressure, but then something is stepping on the water hose and blocking the flow of water from leaving, that pressure is going to build up and that water hose is going to start bulging, right, until it eventually just gives and rips and then water spews out everywhere. Well, that can happen in an aorta, the big artery in the middle of your body, and so it's a bulging of the wall, and if it ruptures, the patient can bleed to death really, really, really quickly, because this is a main artery with lots of high pressure blood, and so you can lose a vast amount of blood into the abdominal cavity. And then it's very hard to save patients from aneurysms that have ruptured. Ideally, you catch the aneurysm when there's that bulging, but the thing is, these are very silent. There's not really symptoms other than the way they catch them a lot of times is imaging for something else, and all of a sudden they're like, hey, you've got an aneurysm here, we need to fix that. So they need to basically go and shore up and strengthen around that bulge and lessen it so that it doesn't rupture. In the brain, an atheroma or plaque can lead to a stroke. And in the extremities, an atheroma or plaque blockage can lead to blood loss and gangrene, meaning that there won't be blood flow downstream from the plaque blockage. And so with no oxygenation to those tissues will start dying and gangrene will set in. Although there are lab tests to detect a myocardial infarction, the main one being troponin, there are others like CK-MB and myoglobin. There are no definitive laboratory tests to detect a stroke or to detect an aneurysm. And last, we're going to talk a little bit about hypertension, because hypertension can cause that damage to the endothelial lining in your arteries and can eventually lead to having heart attacks or strokes. Normal blood pressure is less than 130 over 80 millimeters of mercury. This is systolic, this is diastolic. So this is the pressure when your heart is pumping, and this is the pressure when your heart is at rest, and this is the pressure in the arteries, not in the veins. Okay. Coronary artery disease is associated with hypertension, as is renal disease, and as is stroke also. And again, there's no one lab test to diagnose hypertension. You have to check people's blood pressure and do a battery of other tests, and usually evaluate the patient's physically, but also get his history and track maybe blood pressure over time to see what's going on. And so with high blood pressure, basically you have a combination of genetics in the environment that can cause different things to happen. So insulin resistance, as seen in type 2 diabetes, too much insulin around, which then also will lead to high blood glucose. And that can cause dysfunction of the sympathetic nervous system, the renin, angiotensin, aldosterone systems, such as water balance, the adenosine molecules. This has to do with your cell cytoskeleton and the sodium-potassium pump. and your natriuretic hormones, these are your hormones that are produced when you have excess fluid. They work opposite RRAS system. So the RRAS senses volume depletion and will make you retain salt and water and increase the volume in your cardiovascular system, whereas your natriuretic hormones will do the opposite. They'll sense excess volume and make you dump fluid, okay? So with these, you can get vasoconstriction. So already your arteries are getting constricted from these signals, and that causes increased peripheral resistance, and then you get sustained hypertension. Or inflammation can drive a lot of dysfunction here also, especially chronic inflammation is what we're talking about. Chronic low-grade inflammation is really, really bad for your health, and this can lead to renal and salt and water retention. And because of inflammation, you'll have some swelling and edema, and so keeping fluids, and that gives you a higher blood volume, and that can give you sustained hypertension. So again, this is kind of a very simple diagram, but either way, then sustained hypertension damages the endothelial lining, which then can cause atheromas, which then can cause heart attacks and strokes. So hypertension, and it can be also the cause of renal problems. It's a big problem, something that needs to be addressed and well managed. But it's complex because there's so many things in this equation that can be out of whack, and it varies from one patient to the next. All right, and that's the last slide. So if you have any questions, if you're in my Nearpod, you can put them in there, email them to me, or you can drop them below in the comments. Thank you.